to make modifications to how you would normally position the patient. So an example we just saw earlier was with the elbow. If you want to do an AP elbow on the patient and they can't straighten out the arm, what do? Well, now you just do 2 shots of that elbow, right? One with the humerus flat, one with the forearm flat. Okay? That's one way you can modify your exams for trauma. Okay? If the patient has a broken leg and you're trying to figure out how to do a lateral because the patient refuses to turn their leg, what could you do?
Turn the tube side.
Great, you can turn a tube. You can do it cross table, almost like a decubitus, right? So you do a lateral, directly AP, and then you turn the tube sideways to get your lateral. Hey, it's important that you do make sure that you are trying to get 2 views of the anatomy. Trauma should be demonstrated in orthogonal planes. It should be demonstrated in 2 images that are 90 degrees to each other. Right? So at minimum, trauma should have an AP view and a lateral view. Why do you think this is?
Foreign bodies.
Foreign bodies. Okay, why, if there's a foreign body, why would you want an AP and lateral view of the foreign body? Why not just an AP view?
To get it in its entirety.
To get it in its entirety. What does that mean, in its entirety?
From all directions.
Why does it matter that you look at it from multiple directions?
You don't want to miss anything.
You don't want to miss anything, you don't want anything to be hiding.
Fractures.
All right, so let's say that I've got a fracture, right? So normally this is the bone. And now let's say there's a fracture like this, right? Which way is the bone separated? The bone is separated vertically, correct? Superior, inferior. Is that the only direction the bone is separated in?
From this view, it's hard to tell.
Which way did the bone move? Forward. Also forwards and backwards. Hard to tell like this, isn't it? Easier to tell when you have a second view at 90 degrees, right? That's why you need orthogonal views. Because on an AP, you can tell if the fracture goes left to right, right? If it's AP, you can easily tell left to right, but it's hard to tell front to back. On a lateral, you can see front to back, but you can't really tell left to right. So that's why you need both views. Okay, you always try and get 2 views for trauma. Dislocation. What is a dislocation?
When the bone separates from the joint, or the joint separates or moves out of the space that it's in.
Okay, Mansi?
The bones are not in their normal position.
Okay, not in their normal position, separates from the joint. Anyone else? Dislocation?
Pops out.
Pops out. All right, great, right? That's the simple answer, right? Pops out of the joint. Bone pops out of the joint. But yes, the idea here is that normally there's a bone. It's supposed to be connected by a joint to another bone. Now they have separated. They are no longer in contact. They're no longer articulating. So something that you'll commonly see in clinic will be something like a shoulder dislocation. Okay, shoulder pops out of socket, either went forwards or backwards, and so the doctor will need x-rays to 1, make sure that the bone is actually dislocated, and 2, figure out which way the dislocation went. Did it actually pop out anterior, or did it pop out and go posterior? Once again, that is why we need both views, both AP and lateral. By the way, if you ever do get the chance to, sometimes immediately after doing the x-ray, doctors will try and put the bone back in place. And so if you have the opportunity to stay and watch, that is certainly a very interesting procedure. Yes, Jay?
It's a very interesting choice of words. But this doesn't always require like a hospital visit or anything like that, right? Like you can just naturally deal with this.
Yes, so with dislocations, it depends. Some people are more prone to dislocations. The bone just pops out, and then it may just naturally pop back in again.
Wait, how does the doctor put it back?
Depending on how bad the dislocation is, I've seen a situation where the patient was on the bed, one doctor had a sheet wrapped around the patient's torso, pulling towards the right. Meanwhile, the patient is standing on the stretcher with the patient's arm bent, yanking it towards the left. And yeah, that was very interesting. It was like trying to use this knee to like force the shoulder back down into the socket. Yeah.
That works?
Very distinct sounds.
Did it work?
Yeah, it worked.
I thought it worked.
It went back.
It's like, yeah.
Then it probably
After
broke.
that, like when you put it back in, is everything all good or?
Is it sore?
So yeah, it's gonna be sore, but it should be okay. It may or may not increase the chance of it happening again down the line. But
Like the ligaments and
I
tendons
saw
are a little.
the guy.
For real?
Yeah, it was an old guy. He wasn't complaining that much. He said usually guys were like screaming and shit.
But so if you take a look here, this is a mixture of the shoulder. You haven't learned shoulder yet, that's okay. But this here is an AP, and this here is a lateral. So you can see in the, so from this AP, it's kind of hard to tell that it's out of socket. But on the lateral, this is where the joint is, and this is where the head of the shoulder is. You can see that it has shifted, right? Once again, orthogonal views, very important.
Have any of you guys seen that in clinic yet?
I think Melanie said she has. Anyone else had a chance to see that in trauma or main EC? No? All right, well, you'll have 2 years. You'll have 2 years to see that. Okay. Next up is subluxation. This is just a minor dislocation. Okay, so the entire thing doesn't come out of the joint. It only comes part way out of the joint. Okay, so dislocation is all the way. Subluxation just halfway. In this case, what has been subluxed? So we're actually not looking at the shoulder this time. We're looking here at this joint here, the AC joint between the clavicle and the acromion of the scapula. Normally they go end to end. This time you see it's slightly up. It's like halfway off the joint space, right? So part way off, subluxation. Okay, sprain. So this happens when there's a traumatic motion, like a strong force. So in this case, right, wrenching or twisting. So it disrupts the ligament. Ligament normally holds the two bones together in place. So now that the ligament is no longer functioning properly, the bones can separate and you have this unnatural widening of the joint space. Has anyone seen stress views of the ankle in clinic? No one's had a chance to see a stress view yet. All right.
What is a stress?
Oh, yes.
I've seen them doing x-rays of the ankles.
Mhm.
I don't know what stress view.
No, it'll say stress view.
Yes,
Oh.
the stress views are a unique position, and their job is to visualize this gap. So if there is a loss of ligamental function here, ligaments not holding the bone together properly, you will see this space widen
Is that,
on the stress view.
is that like the ankle equivalent of like weight bearing on the knees?
Yes, in a way, yes. So weight bearing, it's a way to stress the joint to check the spacing. Same thing here. Only difference is this is forcing the joints more open rather than more closed.
You will learn that the stress view, the physician's supposed to do it, but at Ben Taub, you'll see that they don't actually physically grab on the ankle and make a stress on the ankle, but they'll dangle the ankle, they'll raise up the ankle and let it dangle, which will put stress on it. So they're not physically doing a stress
Right.
ankle view.
It's a gravity stress.
Gravity, yeah. I know.
Okay, contusion, it's just a bone bruise. Right. Easiest way to think of a contusion is just a bone bruise. Avulsion fractures, we'll talk about later, but that's simply a fracture that happens when you've got a tendon or ligament that pulls on a bone and it yanks off a part of the bone with it.
So bone bruise means?
So you know what a bruise is?
Yes, sir.
Okay, and just imagine the bruise on the bone.
And
It's a bone bruise.
that is sure, that you can see as well, sir?
So that's a contusion. So it's really hard to see contusions in x-rays. Normally you would need something else like an MRI to see a contusion. Okay? But I'm just going over all the different types of trauma right now.
Can you see it on that image, or is it hard?
Yeah, so the contusion here is going to be right here. It's this unnatural white area that you normally wouldn't have. So this white here is fluid, right? So it's the bleeding from the bruise.
On the lateral side.
Yeah. And what?
Yeah, you've also got a little bit of extra. So this,
Now you see where the
oh,
yeah.
yeah. You've also got a bit of bruising right there.
So what do you mean by avulsion factor?
Avulsion fracture, like I said earlier, avulsion fracture is what happens when you have a tendon or ligament that pulls on the bone, and when it pulls, part of the bone comes with it.
So dislocation.
Not a dislocation. A dislocation does not involve the bone breaking. Fractures involve the bone breaking. Okay? So, either we have a force that is applied directly to the bone, right? So the force comes here, hits the side of the bone breaks in half, or there's a force transmitted along the shaft of the bone. Okay? Now, very important with fractures, never force a body part into position. If a patient has a fracture, you are not going to try and force the patient, you're not going to grab that leg or that arm and manipulate it into your proper positioning, right? If the patient has a forearm fracture, you're not going to grab that arm and that wrist and twist it so it is AP, right? If the patient has a femur fracture or a tibia fracture and the foot is laying sideways, you're not going to grab that foot and twist it AP. If you do that, you can cause further damage to the patient. The bone is sharp, it can cause cuts or tears into the muscle, you can sever a nerve, you can cause paralysis. Do not manipulate body parts when there is a fracture. You are not going to force any body parts into position. You will ask the patient to do the most they can do, and that is it. If you do need something moved, guess who moves the body part?
Patient.
The doctor.
The doctor. So patient if able, if not, the doctor is going to be the one to move the body part into position for you. However, normally you're not going to have a doctor on standby to help you with every single exam. So what do you have to do? You need to get creative. You need to find ways to get the x-rays, get the images necessary while moving the patient as little as possible. Okay, that is the key to trauma radiography. You need to be creative, and you need to find ways to get the images you want while moving the patient as little as possible. Does that make sense? Are we clear on that?
Yes, sir.
Yes, Reagan.
How do you know for sure that it's broken?
That's a great question. So let's say that you have a patient, you're there to do an x-ray, you suspect there may be a fracture, but you're not sure there's a fracture, right? The reason for exam is trauma, or it's MVA, right? Motor vehicle accident, right? Or it's fall. Something that tells you there could be a fracture, but you're not sure. What do? First, you ask the patient how far they can move. What is the limit of their motion? What is their range of motion? Are they able to put their forearm all the way AP? Or is their forearm stuck somewhere here and they can't turn it anymore? Right? Depending on what they say, you might be able to proceed as normal, or you might need to go with what they give you. You do those first images and you look at your images to see if you notice any fractures. Now, that doesn't mean that you're going to go and immediately report to your patient that, oh, hey, you do have a break. No, that's not your job, right? Your job is not to diagnose. Your job is not to inform the patient. Your job is just to take the x-rays. So if you do see a fracture, now you know that you need to be careful of how you move the patient from now on. So you need to think of some ways to move the patient without forcing that body part into position. If you don't see any fracture, then keep working with the patient. Ask them to move into position as much as possible to get the images you need. Okay, but that first initial picture look at it carefully to see if you do notice any fractures. Right, that will determine how you proceed. Great. Any other questions? All right. Whoops. All right. So just some really basic alignment terminology. We've got two ways to describe fractures. One is apposition. It's basically, are the fragments still lined up or are they separated? Right. And then we have angulation, right? Are they in a straight line still, or are they now at an angle to each other? So we've got anatomic apposition here. Do you see the fracture along the shaft here? This dark line right there? Right, so there's a fracture, but as you can see, the bones are still perfectly lined up with each other, right? So the ends are perfectly in contact.
Is that the same definition as the last slide, or is this?
So these are types of apposition. Right, so this A here, this is your anatomic apposition. Right, over here, right, now we have some shifting of our apposition, right? So here it's no longer perfectly in alignment, it's slightly off. Right here it's no longer in alignment, it's slightly off. Do you see that?
Excuse me, sir.
Yes.
So I didn't understand what a position means.
It's just, are these two bones lined up? Do the edges match?
Yes, sir.
Okay. Do these edges match?
No.
No, slightly off, right? Do these edges match?
No, sir.
Even further off, right? That's the concept of apposition. How closely are they lined up? Okay. We have distraction. If you are in OR or in surgery, you will hear doctors ask in the middle of cases for extra distraction on the limb. Right? This is just a pulling apart of the bones. Right? So you pull the two fragments apart from each other. That is distraction. Right? So add on traction to increase distraction. Traction is just the pulling motion. Right? So you see the difference between this, right, versus these here, right? Still touching, versus distraction. There's a gap, a space between the two bones. All right. Here's a fun one, bayonet apposition. So who can tell me what a bayonet is? Jay?
It's a large knife on the end of a weapon.
Large knife on the end of a weapon. Okay, Samantha?
Something I know it's some type of weapon. Is it like a club?
Like a club. Usually it's sharp, so usually not so club-like.
All right.
So a bayonet, right? Let's imagine that you've got a gun like this, right? And imagine that this is really early on, like the 1700s or the 1600s, right? You've got a gun. This gun can shoot maybe once every 15 to 30 seconds. So you've got a soldier charging at you. You've got your gun. You shoot your gun. The gun sucks. It misses, right? And now the soldier is almost on top of you. And you have to spend 15 to 30 seconds to reload your rifle before you can shoot again. What are you going to do? Well, what you're going to do is you're going to take your gun, and you're going to stick a knife on your gun. So the knife is going to be hanging here underneath your gun, right? So you shoot, you miss, all right, you're trying to stab them instead. So do you see how these two are like on top of each other or next to each other, right? They're not in line, they're on top of each other. Same thing here. Do you see how these two shafts are next to each other? Do you see how these are next to each other? They're not lined up anymore. They're like on top or side by side to each other. That is bayonet apposition. So not only did they fully separate like this, but then they slid in next to each other. Why does this happen? It's because the muscles have tension, they pull the bones. Normally the bone is intact, so it resists the muscle. But once they slide like this, the muscle